Good morning, and thanks for joining us for this session. My name is Wayne Barfield. I'm a respiratory therapist at the Medical University of South Carolina, working with the adult and pediatric CF centers. This morning, we're going to talk about innovative ways that you can help your team and your patients manage their CF care. I have no financial disclosure or conflicts of interest to disclose. Some of our objectives today, we're going to identify what CF patients face each day in their daily life. We're also going to find ways to help them become more efficient and productive and explore ways to help your team provide better care as a team effort using some of this technology. And also, and last but not least, use technology and explore the ways it can help these patients manage their care. First off, we're going to get some of the data behind us when it comes to treatment compliance. As you see here, patients are the most productive with their digestive enzymes. And in this study, they're the least productive with their chest physiotherapy. It was known that patients completed the treatments that they felt helped at a greater influence in their quality of life. And digestive enzymes, as many of you would guess, would probably be pretty important for them. This study also looks at chest physiotherapy, in which 29% reported undertaking daily chest PT. And in both these studies, these patients were self-reporting. So it could be even a little less than what was stated. And some of the reasons, as you see here, there's quite a list of some of the reasons why patients felt like they weren't doing their chest physiotherapy. So it's kind of like all the above. It could be anything depending on what's going on in the patient's life. But I mean, everything from it felt like it made them nauseous to they didn't have the time, to they were too tired, all these different things. And I think as a team, you should be able to come together and find ways to help kind of minimize some of this, or at least brainstorm. The most important things that patients said in that study is that they didn't have time and that they were too tired. That was one of them. They did mention exercise as part of it. As we all know, there's different level of exercise depending on what the patient reports to you. And as you can see, this is also a wide variety. If you're wanting to know a little bit more about adherence and CF, these are two really good articles that were written. There's a literature review on adherence, and there's also a good report on adherence with nebulized medications. So just to kind of give you a deeper look if that's something you're interested in. So one of the keys here that we're going to start off with is balancing. For a CF patient to be successful, they need to have good balance in their life. And we want to help them become successful. And success means something different to everyone. You can ask your team what they define as success. You can ask a patient what they define as success. You can ask a parent or a spouse, and everybody's going to have a different level of success. And what we need to do as practitioners is find ways to help this patient find a good level of success. And let's be realistic in what can be accomplished and set some realistic goals and find a good balance in their life. As many of you know, the key to a good, strong life is a good foundation. We want to make sure our patients have a good foundation. I'm lucky enough to work in the pediatric clinic also, so I'm able to see a little bit of that continuity when the patients do cross over to the adult clinic. But it's really important that even if you don't work with a pediatric population, that you meet up with the pediatric team near you and find ways to make sure everybody's on the same page. Because we all know if we start patients off on a right route, we have a lot better success helping them with a good foundation. One of the ways and these are just some of the tools that we do for our patients, and this is something that's always evolving. First off, before our patients are even seen, we have a CF preclinic survey. Our social worker sends this out via MyChart. That's the medical documentation system we use. And it's pretty much emailed to the patient. And on here, they identify several areas that they feel like may be important for their upcoming visit. And this is usually sent out the week before. And this helps us identify any specific needs that the patient has. This also gives us time during our meeting, which you'll hear about next, ways for us to troubleshoot and do things. The survey is just, it goes into what healthcare team member needs. But one of the important things is the patients have to identify specific goals they have for their care and also identify some of their biggest barriers. This helps us as a team brainstorm and come up with ways to help them. On Mondays, the day before, we have a pre-clinic meeting. In the past, we've always met around a big table in which everybody gets together, and this is our whole team. And with COVID, obviously things have changed, but we started doing WebExes and Zooms and having these meetings. And this is a good way for us all to talk about and discuss what our needs are for the patient. But then it's also a good time to go over, PFT trends, labs that need to be collected. Is the patient due for anything? But also a good time to see if there is any obstacles, and maybe we come up with a solution, or at least brainstorm that solution, because everybody brings a good thought to the table. Our CF clinic visit. So one of the things that you see here is we have Dr. Flume here with a patient, and then also here to the right you see, or your left, you see Dr. Flume and the Zoom call or Doxy or whatever software you're using. But our clinic is kind of taken, when COVID happened, we were lucky enough to be one of the centers that actually had access to telemedicine. And when COVID happened, it gave us an opportunity to kind of kick it in gear and take it to the next level. And we thought we were kind of ahead of the curve in this area. But also what we found was we went to all virtual, and now we're doing what we call a hybrid model. So we have inpatient visits, and we have Doxy visits or WebEx or whatever, where the virtual visits with the patients. And this gives us an opportunity to find out kind of what the patient's needs are. Now, it's also important to think about some of the pros to this is when your patients may come from pretty far away. We have some folks that drive 4 hours away, pretty regular, and a 4-hour ride to a CF clinic visit, and then you come for the visit and then you have to go back. It's a full day affair. So this is definitely a tool that's been there, and this is always evolving too, but this is a good opportunity for our team to be able to see them. And we put the iPads in the room, and just like the patient would be in there. And when we have to go in there and see them, each one of us pops in and sees them and pretty much tags a team member once we're wrapped up. Another good thing at the end of the visit is, and this is definitely, I see a lot of, like in more of a pediatric clinic, but we also see it in adult clinic. This is just a sample. This is not what we use, but this is a sample of a CF action plan. When team members go in, we cover a lot of different things from a lot of different team members. And when you've got 8 or 9, 10 people coming in, throwing things at you, this is a good way to kind of follow up and make sure the patient has a clear understanding what needs to happen. Now, the next day after our clinic, we all come back together and have another meeting to go over our post-clinic meeting, because we have 3 providers. They're all doing different things. We might be in a room. The dietitian might be down the hallway, social work. So the point I'm getting at is it's like an intersection. Everybody's coming and going. And this gives us a way to kind of follow up and state whatever specific needs we have for the patient, but also gives us a way to update the rest of the team where we are at with it, kind of what our plan is. This is done also via telemedicine or Zoom or whatever the platform is at the time. But this right now, since we're with COVID, we are still meeting virtually. Now, one thing to think about with your CF clinic is, like I said, I thought we were one of the clinics that was kind of ahead of the curve. And then when we look at this survey, our psychologist did this survey with our team. And one of the things about QI and surveys is it's very important that you're honest with yourself, because the only way you can make changes for the positive is by being truly honest with what's going on. And this was our team, how we tracked the way we felt our clinic was going. How are we functioning as a team? What is the burden? Are we satisfied with it? And these are all of our team members. As you see, we started this in May and it just ended in September. And we started out pretty low, but it's gotten a lot better. And as we have a separate one for our pediatric clinic and a different one for our adult clinic. And we kind of have 2 different approaches. But there's an abstract being done on this, and this is just to point out that we're always trying to find ways to see where we're at. It's important that as tools, we look at what we've got here. I'm a Boy Scout, so I always laugh about this, but like you've got the little knife there on the left, and then you've got this obnoxiously big Swiss Army knife on the right that I've never seen anyone carry in my life, but it's basically every tool you could possibly think of. And I like to think of a CF as what kind of tools are we giving our patients? What are we doing? Do we want to give them one or two tools to help them, or do we want to be creative and think outside the box a little? One of the things that we want to think about is back to the basics is time management. Time management tips. These things are online. You can find them anywhere, especially with like project management stuff and things like that. But it's important for these patients and us to think of what's priority. What are the realistic goals? Are we setting, are patients organized? The more we can help them do this, the better they're going to be with getting this stuff in, hopefully. At least that's the hope. And be able to identify that. Now, this is where multiple team members come in. Psychologist, social worker, dietitian, everybody is going to come together and try to set some of the same goals so we know what's a priority. If their weight's down, then maybe at that time, then we look at prioritizing some of the nutritional goals. If their PFTs are trending down, maybe we look at what do we need to do to get the patient's PFT numbers back up. It's all what it is. But the thing is where I was trying to go with this is that it's important as a team that everybody brings some cool ideas, because there's lots of really good things to share and lots of good tips that you can do. Now, one of the newest technologies that's out and about, and this has been all over listserv, is home spirometers. We tested several out. This is the one that the CF Foundation is providing. And as you see, you've got some basic PFTs here, and there's games. And who would have thought 5 years ago that this would be a realistic thing that we would be teaching patients about? And the key to these things is getting some reliable data and being able to coach the patient. And now that 4-hour ride may be avoided if you can get a PFT at their home. So it's important to think of some of the tools that are out there. But it's really neat with these games and technology always changing. And this also gives patients the ability to manage themselves at home and see what's going on before they become really sick. Now, right here, I've got some productivity apps. Now, here's the thing about productivity. It's what you put into it. I have my chart here, the red folder with the heart. That's important because that's one of the systems that we use. Your hospital may use another, but this gives the patients access to what their results are, what they need. Are they due for anything? What their sputum culture showed, anything. They can find it in here. If they want to message the team, they can do that. We have Evernote on here where patients can take notes of what's going on. Also, in addition to that, post-clinic paperwork that they're given. Microsoft To Do. I don't know that the patients really deal with this as much, but our team utilizes this sometimes. It's a good way for us to message each other back and forth really quickly. Todoist. These are all lists. Lists are super important when it comes to identifying some of the things that need to happen. Patients, when you look at all aspects of their care, they have multiple things to take, and it's hard to manage that. One of the things on the left here with the S, that's one about like helping you with like setting 6 daily goals. And what it does is basically as you hit those goals for the day, you check it off. On the bottom right there where you see the Habitica one, that's a gaming calendar. So as you do your task and complete them, you get rewards. It gives you rewards to do it. And that may not work for everybody, but that may work for a young adult that's into gaming. Google Calendar. We all know how attached we are to those things. We just go where the calendar tells us. And that's important that we help patients use the reminders and things like that. These are all opportunities for patients to be able to increase their productivity. And next thing is activity apps. I've just got several on here where we look at like this gives you an idea that patients, there's a wide variety of things they can do. You'll see everything from a kettlebell on here to the all trails, the hiking one in the green, daily yoga, Fitness Pal, Nike Run, YouTube, whether we like it or not. There's a lot of areas to learn from on YouTube. When it comes to like, I've seen a lot of care centers around the country put nebulizer stuff, airway clearance. There's exercise workouts, there's HIIT workouts, there's all these things. I even found an app the other day called Zombie Run. It's not my cup of tea, but it basically it gets the patient running, and as they run, walk, they have tasks they do that are exercising, and as they do, they get, it's kind of like the Habitica app. You get supplies and get points, and it helps you in the game, but it gets you exercising. The thing is that we need to find what identifies with that patient to help them be able to manage their stuff. And if it's reminders or activity apps, or even if it's the health thing on an iPhone to tell you how many steps you're getting in a day. It's amazing what we can find out with the phones that we carry in our pockets all around. One of the things that our team does is we have a quarterly newsletter. And this quarterly newsletter is called The Breather, and it covers different topics that we cover with our patients. And it's really cool because it's like a 3 or 4 page thing, and it covers everything from resources to team member patient spotlights. With a young man that runs cross country, we thought it was important to know that. Different events going on in the community, recipes, wellness corner tips. But this goes out emailed to patients, and they get it through various forums. But this is just a good way to communicate what's going on with our team, what's going on in research. One of the things that we've also implemented in the last year is a patient family advisory board. We had one in the past, but now we're really getting some of these cool ideas from our patient families. We have pediatrics on there, we have adults on there, we have spouses, we have patients, we have all the above. And this is always evolving and changing to give us some fresh new ideas. Smart reports. Look at some of the med recs that are available now. It's highly dependent on how it's reported, but it's important to know that, you can do that. Some of the vest companies have ways to look at how often the patients are doing the vest, but it's this technology that we can use to help us make better decisions. I was talking about the quality improvement. The CF Foundation hosts QI stuff every few years, and our team is one of the ones that's been involved with the lung transplant dissemination. And it's huge. This has helped our team in so many ways with getting organized and making and setting goals the proper way and helping us be able to do what we need to do. CF resources, you know what's out there when it comes to that, but we want to make sure that patients know that too. So we want to make sure that these things are out there. There's blogs, there's just all kind of things. There's just really cool activities. And it's important as team members that we understand this for patients saying, let's be flexible. Here I have a country in the country of Georgia, 6,200 miles away. This is one of our guys that flies out halfway around the world literally for a clinic visit. It's a $2,500 flight. So you want it to be productive. You want to be, and I just want us to know that just keep flexibility in mind. We'll work with them and understand limitations. What we want to say, what they want to hear, and what's relevant might be totally different to each other. So I just think that about it. And then also remind ourselves, because it's easy for us to ask a lot of questions, but we want to make sure that we still keep reminding ourselves, these patients, this 2 to 3 hours of their daily life, that's 21 hours a week just to taking care of themselves. It's a lot of tasks, and it's not always easy. So I just hope that we can find ways to be more innovative when it comes to helping them clean things faster or being more productive with exercise, whatever the case may be. But just keep in mind as team members, we're always asking and asking and asking a lot. And with these new drugs on the horizon, hopefully we can help these patients feel much better with it. And in closing, I love this quote. It says, coming together is a beginning, staying together is progress, and working together is success. Take advantage of this. Everybody working together, we all have the same interest, and we all want our patients to do the best we can. And at the same time, we want our teams, our patients, and everything to be smooth so everyone knows what needs to happen and finish off on a good note. This is part of our CF team last year in Nashville, and I can't say thank you enough to all of them for everything they do. I work with the best group of people in the world, and I'm super thankful each day to work with them and everything that everyone brings to the table. And thank you for your time.
Welcome to A Patient's Experience of Pregnancy with Cystic Fibrosis. I'm Lauren Mitchell, a physical therapist at Johns Hopkins Hospital in Baltimore, Maryland, and today we'll be speaking with Megan Lepore. Neither speaker has any relationship to disclose related to this presentation. The number of pregnancies in the U.S. cystic fibrosis population has increased over the past 20 years, and older data suggests that over 50% of women with CF are able to conceive. Pregnancy, even in a healthy woman, is a time of much anatomic, physiologic, and psychosocial changes. These changes in the setting of someone with CF require a woman to closely consider many factors when planning and experiencing pregnancy. Today, I have the privilege of speaking with Megan Lepore, an adult living with CF, about her experience with conception, pregnancy, and motherhood. Megan, if you don't mind introducing yourself.
Thank you, Lauren. My name is Megan. I'm 35. You can see my husband, Bobby, and my son, Henry, in that photo. He is 13 months old, and that was on his first birthday back this summer. I am predominantly a stay-at-home mom right now, but I also work with the Cystic Fibrosis Reproductive and Sexual Health Collaborative.
Great. Thanks, Megan. So before we get into the details of your actual pregnancy, I know that a lot of thought probably went into your decision-making about getting pregnant. We know that 1 in 30 Americans are carriers of a CF mutation, and only of those people, only 1 in 8 of them actually have mutations that don't show up on the standard panel. What sort of thoughts and conversations were you and your husband, Bobby, having when it came time to decide about starting a family?
Sure. So upon the advice of my CF team, we definitely wanted to get him tested for the CF gene because we did not know if he was a carrier or not. He initially, the test he got was through his primary care provider, which was just that one standard panel you mentioned, Lauren. And we were advised by my CF doctors to really try to get a full genetic sequencing. So I called the CF Foundation's Compass program to help direct us to resources to get that done. So we worked with a company called Council that helped us do a full genetic sequencing for my husband, and he did not turn out to be a carrier.
Okay. And then how about any other thoughts about CF? Did you take anything else into consideration when you were getting ready to plan for your pregnancy?
Yes, so I met with 2 different specialists. One is a maternal and fetal medicine specialist, a high-risk OBGYN, who was willing to take on my case and would be available to me as soon as I became pregnant. And the other person I met with was another OBGYN who happened to be a reproductive toxicology specialist. So even though he didn't have a lot of experience with CF himself, he has a lot of experience looking through animal studies and human studies of all different kinds of drugs. And so he was able to give me some advice on the types of medications I was on, particularly Orkambi at the time, and the various safety profiles.
Okay, interesting. And then how about in clinic? Who in clinic was a part of the decision-making? And then in hindsight, was there anybody in clinic that you wish had been a part of the decision-making?
Sure. So from the beginning, my pulmonologist, my primary CF doctor, was part of that decision-making process, and she had recommendations for my drug treatment and pregnancy treatment. I also worked with the nutritionist to make sure that my nutritional needs were being met. Later on down the road, conception took a while for us. I met with an endocrinologist who works with CFRD patients. And the one person I wish I met with a little bit earlier, specifically about pregnancy, was our clinic's pharmacist. He had a lot of helpful information that also lent to the decision-making of what drugs to change and what drugs to stop and what drugs to stay on.
Okay. So then when you were starting the process of getting pregnant, how about from a lung function or BMI or blood sugar, any of the common things that you need to get prepared for? Did you have to pay any special attention to any of those?
My lung function was fortunately pretty stable. I did have one exacerbation when trying to conceive, but otherwise was fine. Same with BMI. My BMI was a little bit on the high side, so the nutritionist worked with me on maybe some healthier snacks to get it down a little bit to help with my diabetes a little bit. Blood sugar was the biggest challenge for me. And that was something that I really started to take more seriously the further I got along in our conception journey.
Okay, so then you're calling it your conception journey. Tell us a little bit about it. What happened?
Yeah, so we started trying to conceive back in the summer of 2016, and we were advised that because of my CF, I might have thicker cervical mucus and conception might be harder. So after 6 months of failing to conceive, we met with a reproductive endocrinologist at a fertility clinic. We did a battery of tests, everything looked fine, so we started down the process of fertility treatment. I did 6 rounds of intrauterine insemination, which included 2 very early pregnancy losses. And then we started doing IVF. And we did 2 rounds of IVF that had 1 round of an early pregnancy loss and just generally disappointing results. And then we did a 3rd round of IVF at a new clinic, and that one worked right away.
Okay. Okay. So now you're pregnant with Henry. At this point, do you know it's Henry yet, or did you wait to find out your gender?
Yeah, we didn't know when he was implanted, but at 8 weeks gestation, when we graduated from the clinic, we asked the doctor what we were having, and that's when we found out.
Okay, so we know we've got Henry coming. Tell us a little bit about how the pregnancy went, and what in particular did you need to change? One of the things that I know a lot of us would love to hear about is airway clearance. We know that estrogen and hormone levels increase a lot during pregnancy, which can increase congestion for any pregnant woman, let alone increase your mucus for a woman with cystic fibrosis. So what did you need to change?
So I came off of a couple medications early on and did some tweaking with my team. And as part of that, I wanted to make sure I was really still doing my best, at least 30 minutes twice a day, sometimes longer, to compensate for, the rising shortness of breath and the changes in medication. As my pregnancy went along and I got bigger and bigger, I started, unbuckling the bottom buckle of my vest. And I think I was about 6 months along, and I came to clinic, and the PT said, "Do you want us to order you a new vest? We can get that." And so we did that. We ordered a shorter one that really just covered my top half. So that was very helpful as we went along too.
Okay, so you changed your pulmozyme, changed the medications. How about any complications? Some common ones for women would be constipation, incontinence, musculoskeletal pain, any of those?
Yeah, so I didn't have any incontinence, fortunately, but I'd had a history of constipation, so I was prepared for more of it, especially with the fertility treatments and getting additional injections of progesterone. So I really upped my Colace. I was taking Miralax more than typical for me. Musculoskeletal, I also have a history of back pain. And around the end of my 2nd trimester, beginning of the 1st, it started to get really hard for me. And I worked with one of the PTs at clinic to learn different exercises I could do to try and strengthen my core and stretch out my back a little bit. Upon their advice, I also got a ball chair that I still use because it's so helpful. So those kinds of things really helped me out a lot because that was starting to become a real challenge.
Okay, speaking of exercise, just your general exercise. Did you exercise before? Did you do anything different now that you were pregnant?
Yes to both. So pre-pregnancy, I did ballet, I did yoga, I did bar fitness and cardio. And once I became pregnant, I really focused in on workouts that I knew were designed for women who were expecting. I didn't want to have to go to a yoga class and worry. I think I actually did this a couple times. I went and I was like, can I do this pose? Is this okay? And that was just more stress than I wanted to take on. So I really focused in on YouTube videos that were designed for prenatal workouts.
Okay, and did you find all that on your own, or was there any resource, or did somebody point you in the right direction for that?
Yeah, I really just found those on my own. I had already done some YouTube workouts pre-pregnancy, and so I just looked at some of my go-to spots to see what else I could find.
Okay, so maybe an area of education for us therapists out there that we can preemptively give to our patients. How about, you mentioned shortness of breath a little bit. We know that your diaphragm is elevated as the baby's growing in your belly. Did your breathing feel different, or what were you noticing from a breathing point of view when you were pregnant?
Yeah, I definitely noticed that, as I was taking my walks, I would get out of breath more quickly. I felt lucky. I felt pretty healthy most of the time, but I definitely found myself like gasping for air a little bit more.
Okay. Okay. Anything else big or major that happened during, oh, you know what? Forgot to ask you. Exacerbations. Did anything happen from that point of view?
Yeah, so several times in my pregnancy, I experienced a little bit of hemoptysis, which was scary to me, but it always stopped pretty quickly. And my clinic told me, this is normal, even though this isn't your normal, as long as it doesn't escalate, you're okay. And so I never had to go in for treatment for that. But I did need to go spend one night in the hospital. One Saturday in the middle of my pregnancy, I was spiking a fever. I started to feel like I had a cold. I didn't know what was going on. And so they advised that I come in for observation. And by the time I got there, my fever was coming down. So they said, okay, we're just going to watch you overnight, but we might need to start IV antibiotics. And by the morning, I'd been diagnosed with the flu, even though I always get my flu shot. But with that diagnosis, it was actually good because they said, okay, here's your Tamiflu, go home, take care of yourself. And I was completely fine.
Yeah, you're right. In some ways, that's a good diagnosis, but also really not fair for a pregnant woman to get the flu during the middle of her pregnancy. Oh, I'm sorry you went through that. So, okay, in terms of the hemoptysis, did you change anything, or did you just keep your normal course of airway clearance and exercise?
The first time or two, I pulled back on my airway clearance for about 24 hours to make sure I was okay. And I worked with my pulmonologist, and she said this was fine for me to do, but she also said, relatively speaking, it was not that much blood, so I could continue if I had felt comfortable with it. But however I wanted to proceed was okay.
Okay. So you got through the pregnancy. It's now time to meet Henry. Tell us a little bit about your labor and delivery and what that looked like.
Yeah, so we decided to induce labor at 39 weeks and 2 days. It took a long time. It was a 50-hour induction that actually ended in a C-section. I never had a real preference of vaginal delivery versus C-section, but my CF team and my OBs were all saying, really for you, it's much better to have a vaginal delivery because of your lungs. We don't want to put you through an unnecessary surgery. And so I feel like with that in mind, perhaps they let my labor go on a little too long. I ended up with some complications. I ended up with an amniotic fluid infection, probably from the long labor. Henry was in some distress. He had inhaled meconium, and so they had to suction his lungs when he was born. And he also had low blood sugar that required a few days of NICU treatment. And so it was a scary start. I think that I'm used to advocating for myself in my CF care, but I didn't feel as comfortable in this particular circumstance to do that. And I wonder in hindsight if all those complications would have come to pass.
Okay. Well, I'll tell you what, we call a lot of our patients superheroes, but superwoman to BCF, manage all of that, advocate for yourself, 50 hours of labor. It's an impressive feat. So now you've got Henry. You said he was in the NICU for a little bit, but I think one of the big questions that a lot of women going through pregnancy with CF start to wonder about is breastfeeding. That we know that managing your nutritional balance can be challenging at times, that women with CF have 110 to 200 times the energy need of a woman their age. What did your breastfeeding or attempt at breastfeeding journey look like?
Well, prior to breastfeeding, prior to getting pregnant, my CF doctor had told me, your weight's good and stable in your life, but you might have a harder time if you try to breastfeed. You might not be able to do it for that long, and that, that's okay. I want you to be okay with that. And so since he was in the NICU and needing high-calorie formula and needing a dextrose strip, he really wasn't getting breast milk right away anyway, which I was fine with. I was completely comfortable with formula. While Henry was in the NICU, I did start to pump to get some stuff ready for him. And once we brought him home, he was about 5 days old, I tried to nurse a little bit, but mostly it was a combination of pumped breast milk and formula that he was receiving. And, that was okay. I could make that work for a while. but I started losing weight really, really fast, and it scared me. At one point I realized I'd lost 20 pounds in 10 days, and that was my cue to pull back and stop. And so when Henry was a month old, I stopped pumping altogether.
Okay. Okay. That's a lot. That is a lot. Good for you to recognize that. I know also at the same time you were probably recovering from your surgery, from the C-section. How did that play a role in anything? How are you doing? Coughing, or what was going on from that point of view?
Yeah, it definitely made coughing harder. Certainly the first week or so I was in some pain, but more than anything I was just afraid. Like, I'd never had a surgery like this, and I was afraid of overexerting myself and causing an infection or something having to do with the scar. So I was cautious, and at the end of my pregnancy, I did a round of inhaled Caistin, and with my doctors, we decided that I would do one more month after Henry was born, largely because of the C-section, because we knew I wouldn't be as active and that my airway clearance might not be as strong for a while. We really wanted to be sure to attack the Pseudomonas as best we could, even while I was recovering.
Okay. Okay. And then also during all this, you're managing your health. You're also a new mom. What was it like? What was it like taking care of a new baby while also having all of your own health responsibilities?
It's a lot. It was a lot. I think as CF patients, we're so used to prioritizing our own health, and then suddenly you have this little thing that needs you. And I think the hardest part then, and even still sometimes, is like those morning treatments. Like, okay, are you going to take a nap and I can do this, or you're not? And how do we figure this out? So getting the help from my husband, from family members, at times from babysitters, that helped give me some peace of mind that I could still take the time to make myself a hearty breakfast so that I would have energy throughout the day, do my treatments. These are challenges still, but ones that we've started to build routine around.
Good for you being able to take that me time. And then I think in our last 2 minutes, now that you have Henry in your life and you're a mother, what do you think about when it comes to the future? Do you have any new hopes or fears or thoughts about your cystic fibrosis being a mom?
I think before Henry, and even a bit before Trikafta, I started Trikafta when Henry was about 5 months old. Mm-hmm. It was much harder for me to see into the future. My health was pretty stable pre-Trikafta, but it was just always hard to know what the future would look like. And not that we know now, but I know that my lung function's higher than it's been in 13 years. And, so my hope for the kind of, active motherly participant that I can be for Henry is much higher than it used to be. And so that's really exciting.
Good. It's so nice to hear that. Well, that is all that we have time for today, but there's our references. I encourage everybody, Megan will be with us on our live panel on October 22nd. So if you are able to come join us, if you guys have any questions to get more of Megan's perspective about what it's like to be an adult with cystic fibrosis and going through pregnancy or new motherhood or conception, she'll be there with us. So thank you, Megan, so much for your time.
Thanks, Lauren.
Hi, my name's Emily Rector, and I'm a physical therapist for the University of Rochester Medical Center, specifically the Complex Care Center of Rochester, New York. I'm going to be giving a presentation today called Aging with Cystic Fibrosis, the Normal Aging Process and its Unique Impact on Those Living with CF. I have no relationships to disclose related to this presentation. Before we begin talking about CF-specific aging, we're going to talk about the normal aging process and how this impacts adults with CF. The normal aging process affects all body tissues, including 4 major systems that physical therapists most commonly address. This includes the musculoskeletal, cardiovascular, and respiratory, as well as nervous system. Aging in the musculoskeletal system includes everything from osseous tissues, which will involve a decline in bone mineral density, starting at the 3rd decade of life and continues throughout life, collagenous tissues, resulting in loss of water in the matrix, articular cartilage being more susceptible to breakdown, resulting in decreased range of motion, increased muscle stiffness, decreased shock absorption. Loss of elastic fibers, resulting in decreased tenacity of skin, bowel and bladder issues, and less give to tendons, ligaments, and fascia, causing increased risk for skin breakdown, increased susceptibility to injury, and incontinence. Aging in the cardiovascular system, we see a decline in max heart rate and VO2 capabilities, creating a smaller aerobic workload. Decreased compliance of vascular tissues, resulting in higher blood pressures and reduced cardiac output, reduced vascular wall contractility, and thickened basement membranes and capillaries, creating a decrease in O2 exchange. All in all, this creates a decrease in cardiovascular exercise and activity tolerance. Aging in the respiratory system, as we see that decrease in bone mineral density, we're going to see a decreased height of the thoracic vertebrae, which creates a thoracic kyphosis, which limits the expansion of the chest wall anatomically and leaves the diaphragm at a mechanical disadvantage. We also see muscle atrophy of the diaphragm and respiratory musculature due to age-related changes in fast-twitch muscle fibers, which impairs ability to cough and perform airway clearance. We also see decreased sensation of dyspnea and diminished ventilatory response to hypoxia and hypercapnia, leading to ventilatory failure in certain cases. We see degeneration of elastic fibers around the alveolar duct starting at age 50, resulting in increased dead space and air trapping. Increased inflammatory responses as the immune system begins to change, and a decrease in VO2 max. Again, this is going to result in decreased activity and exercise tolerance and susceptibility to ventilatory failure at times of stress. So we see increased rates of pneumonia and exacerbation in aging adults without CF, as well as with CF. Aging in the nervous system, we start to see a loss of myelin and decreased nerve conduction, a decline in ANS dysfunction, and a loss of sensory neurons. The results of this create impaired somatosensory system and slower response times, leading to increased fall risk. Common problems with normal aging include dehydration, malnutrition, sedentary lifestyle, osteopenia, and osteoporosis. We also see increased susceptibility to injury, illness, and chronic diseases, increased fall risk, and incontinence. Now, when we pair this with CF, we start to see even more issues. Aging with cystic fibrosis, this is becoming more prevalent as treatments get better and better. We start to see our patients living longer and longer. Based on the registry data, those born between 2014 and 2018 are predicted to be 44 years of age at the time of death. And half are predicted to live to be 47 years or older for those born after 2018. Common complications in adults with CF we start to see are cystic fibrosis related diabetes, and this can happen in 40 to 50% of adults. Declining lung function and increased exacerbation rates. We see malnutrition due to pancreatic insufficiency, leading to weight loss, osteopenia or osteoporosis, and sarcopenia. We see dehydration, urinary incontinence, and increased susceptibility to illness, which has always been a factor throughout their lives. So what can we do as PTs for our aging CF patients? The biggest thing that we can really do is screen these patients. So screening for urinary incontinence is a big one that's highly missed. We're going to talk about that in a future slide. You want to do a balance assessment, as we talked about in the past. Even the normal aging process, we see changes in that somatosensory function. You want to promote safe physical activity during exacerbation to prevent decline. You want to promote hydration and proper nutrition for physical activity, and you want to be able to design an exercise program that fits their changing lifestyle and needs. As patients age, they're going to start to have different jobs throughout their life, maybe a family, and different responsibilities that we weren't seeing from the younger adults. So you have to take into consideration, their very hectic lifestyles on top of managing this chronic disease, and how we can kind of streamline, exercise and activity into that. So screening for cystic fibrosis related diabetes is going to be a big thing, because scarring in the pancreas causes disruption of insulin production in about 50 40 to 50% of adults with CF, and 20% of teens with CF. This would mimic type 1 diabetes, meaning their body cannot make insulin, and they're going to need to take insulin throughout the rest of their lives to control this. Signs and symptoms you'll begin to see in someone with CF-related diabetes are going to be increased urination, excessive thirst, fatigue, unintentional weight loss, and reduction in lung function that is not predictable based on their disease course. If you're starting to notice these changes that haven't been picked up by the PCP yet, you need to contact the PCP and the patient's care team to report your findings. Oh, another note, pregnant CF patients should also be screened for diabetes because we know that diabetes rates increase when you're pregnant. Exercising safely with CFRD. So we have to remember as PTs that exercise acts as insulin. As we exercise, the glucose levels decrease as we use this for energy. We recommend that the patient eats prior to exercise or has snacks or juice accessible while performing prolonged exercise, especially vigorous exercise. So think about your marathon runners, long distance runners, people that like a long gym session or a sporting event with friends. You're going to want to educate and have them be prepared for that type of thing. Signs of hypoglycemia are the same in this population as they would be for the regular population. Includes excessive sweating, hunger, fatigue, lightheadedness, shakiness, mental confusion, nausea, or vomiting. You want to monitor the patient and make sure you have a snack or juice on hand if you're working with these type of clients. Aging and urinary incontinence is something that's often missed with CF. I read a study in 2016. And out of 122 patients, they gave a survey, ages 6 to 59 years, and 27% reported urinary incontinence. This was found to be mainly in adults with CF. 11% of those people were men, and 68% were women. This was found in people 12 and older. This was identified as stress incontinence, so triggered by coughing or exercise or an external stress. 25% actually refrain from coughing or physiotherapy to avoid urinary incontinence. So this is big. If we miss this, we might wonder why, they're not being compliant with their exercise program or airway clearance techniques. This may be a big thing that is commonly missed. An intervention for this is going to involve pelvic floor training, strengthening a routine for the core muscles and other pelvic floor muscles. I am not an expert in this field, so I would be referring out to a women's health specialist or a pelvic floor specialist if a patient came my way with urinary incontinence. Another big problem in the CF population is dehydration. Those with CF actually have a decreased thirst stimulus due to lower osmolality in the body. The fluids in patients with CF paired with decreased thirst sensation as we age, this can be very dangerous. So signs and symptoms of dehydration include cracked or dry lips, mouth or tongue, fatigue, general weakness, confusion, low urine output, dark urine color, low blood pressure, tachycardia, increased body temperature, and a positive skin turgor test, which we're going to go over in the next slide. I have here a urine color chart, which is a good reference for patients in general to help kind of self-monitor their hydration levels. Simply showing them this chart is a good way, before they go exercise or just in their general daily life, they can kind of monitor how hydrated they are based on their urine color. And decreasing dehydration risk. I'm just going to move this screen so you can see this picture. There's a couple ways that they can self-monitor, and they can do this skin turgor test. So you're going to pull up the back of the skin. If the skin remains elevated for more than a second, they're dehydrated. If it bounces right back, it means they have proper hydration. It's important to note that CF patients lose sodium about 5 times faster than their healthy counterparts. And sodium is one of those things that's going to help us retain water and hydration. So if they're losing sodium at a faster rate, we can expect them to dehydrate quicker, especially in hot temperatures or when performing vigorous activity. So you can educate them to add salt to their water or energy drink when exercising, and that's a good way to kind of combat this. Water bottles with ounce markers are also a good idea for easy tracking of how much they're actually drinking throughout the day. Hydration through diet can also be a good way to get through this. you know, encouraging fruits and vegetables and incorporating these snacks pre and post exercise. I have a couple examples here of some vegetables and fruits with high water content. Malnutrition is also going to be a big problem in both normal aging and with CF. Due to just a decreased sense of taste and smell as we age, we have decreased appetite, along with depression, loneliness, and social isolation that comes with aging at times. Food can be a very social thing, and that can help. That can be a factor in why people aren't eating as much. Then you have physical disabilities, unable to get to food easily, and malabsorption due to polypharmacy and changes in enzyme production, mucus, or GI bacteria. Now you add CF and you have scarring in the pancreas, which affects its ability to supply enzymes to break down food. And this occurs in over 90% of CF patients. So adherence to supplemental pancreatic enzymes is the way that we combat this. So just kind of staying on patients, you know, if they don't seem to have the amount of energy they need to work out, addressing it at all angles, hydration, nutrition, you know, are they adhering to their enzymes and all of that. Normally in this population, you're also going to see 10 to 30% higher resting energy expenditure. So these people are burning calories faster. That's why they need to be eating more throughout the day than the normal population. Osteoporosis and osteopenia are even more prevalent in CF patients because of the pancreatic insufficiency. So they're not getting all the nutrients they need, they're not absorbing those nutrients. And then on top of normal aging and everything that comes along with that, the decreased bone mineral density is even more prevalent in this population. So what you want to do for that is weight-bearing exercise is more favorable to non-weight bearing because the way we build bone is through weight-bearing. So you want to load the bones. So basically, I have some examples here, just walking, running, jumping jacks, and squatting, as opposed to biking, swimming, and seated exercises. If you know your patient has a lower bone mineral density, you're going to want to screen them for balance and fall risk too, because you can have a higher risk of fractures with these patients if they do fall. The importance of exercise for those aging with CF, it's going to help stimulate coughing and promote airway clearance. It's going to help keep cystic fibrosis-related diabetes in better control, prevent bone disease and strengthen bones, build muscle for functional strength, strengthen breathing muscles, and improve VO2 max and overall lung function. So keeping these patients healthier throughout the lifespan can improve their quality of life as well. Exercise during exacerbation, the research is kind of out on this. There's gaps in the literature when it comes to the effects of exercise during exacerbation or long-term effects. But we do know to prevent functional decline, we should encourage physical activity to tolerance during exacerbation. If these people are in the hospital for over 2 weeks at a time, not moving for those 2 weeks is going to set you a little bit behind in regards to functional strength. So it's a good idea to promote that to tolerance. The next thing that I want to go over is HIIT training, and HIIT training stands for high intensity interval training. And the reason why I brought this into the presentation is because we know our patients with CF are really short on time, you know, especially the aging adults, because they're going to have families and lives. So high intensity interval training can be done at shorter bursts for the same effects as moderate continuous. So HIIT training consists of multiple cycles of alternating between exercising at high intensity intervals for a short period of time, followed by an interval of lower intensity exercise or rest. It has been researched not only in healthy athletes, but also for chronic diseases, including cardiac, pulmonary, and metabolic diseases, and has been deemed a safe way to exercise. So HIIT versus continuous exercise. HIIT actually showed greater improvements in VO2 max, decreased dyspnea throughout the session, greater glycemic control, equal or greater benefits in less time or shorter sessions compared to moderate continuous. Greater improvements in endothelial function and blood pressure, and a greater decrease in LDL and an increase in HDL cholesterol. HIIT and moderate continuous exercise are equally effective in preventing worsening of chronic disease. inducing peripheral muscle adaptations, improving exercise tolerance, quality of life, and improving cross-sectional area of muscles, so building strength. HIIT does burn more calories in a general sense, with a greater increase in post-exercise fat oxidation. So you just want to make sure that they are eating enough to sustain this type of exercise, as they will burn more calories than a moderate continuous exercise. Here's some ideas for building your own HIIT workout. You want to choose your work to rest intervals first. How long do you want to work for? How long do you need that rest break for? Are you going to do an active or a passive rest time? An active rest time can include stretching or breathing or balance exercises at a lower intensity, while your higher intensity exercises are going to be max effort. So determining the RPE, or your rate of perceived exertion, when you're looking at intensity of these exercises. When you're looking at your high intensity interval, you want to be at an 8+, extremely difficult, almost hard to breathe, you're working hard. And then for your lower intensity, you want to be at a 5 or below. So hard, short sentences down to just passive rest, where they're just relaxing. You can build your own HIIT workout here, and I gave some examples. I'm not going to go through every one of these, but you want to make it functional for the patient. You know, what are their deficits? What exercises need to be incorporated? Can we do some high intensity mixed with some lower intensity balance, stretching, flexibility, and kind of be creative with it. Newer treatments for the CF population. One of the big new drugs is called Trikafta, which is a combination of 3 commonly used drugs. And the bottom line of this slide that I'm trying to get to is it's actually helping people with exercise and activity tolerance. So studies have shown as high as a 10 to 14% increase in lung function, or FEV1, in patients age 12 and up, with improvements in sweat chloride, decreased pulmonary exacerbations, improved exercise tolerance, and quality of life. Because these are new treatments, there is minimal information at this time about the long-term effects of these drugs, but from a PT standpoint, it's showing promising results. And in summary, we just want to know that aging adults with cystic fibrosis deal with both the complications of normal aging in addition to complications associated with CF. Working with the patient's care team to screen and manage complications such as malnutrition, dehydration, and CF-related diabetes for these patients is essential, and something that can be commonly missed. Screening for urinary incontinence and referring out as needed can help improve exercise tolerance and airway clearance compliance. Promoting weight-bearing exercise for bone health, as osteoporosis and osteopenia are very prevalent in this population, can be very effective. HIIT training is both safe, effective, and more time efficient for chronic diseases, including CF, and new treatments are offering promising short-term results in regards to decreased exacerbation rate. So yeah, there's a lot of new promising studies and research being done out there, and I hope that you learned something from this presentation to help improve the quality of life and the exercise programs for your patients with CF. I hope you enjoyed this presentation. My references are as follows, and thank you for watching.
Good morning, and welcome to the 4th lecture in this series on PT-RT issues across the adult lifespan. Today I'm going to be exploring the role of physical and respiratory therapy in advanced care planning and end-of-life care. I have nothing to disclose. So I just wanted to outline a little bit of a difference between the way that we work in Canada versus in the United States. So the physios in Canada, we're responsible for airway clearance, exercise, mobility, prehab, rehab for lung transplant, 6-minute walk tests. The RTs are mostly focused on non-invasive ventilation initiation, nebulizer treatment, inhaler technique education, home oxygen assessment, and lung functions. And then we share the responsibility for oxygen titration. Whereas in the United States, the physios are mostly focused on the exercise, rehab, prehab, and mobility side of things, with the RTs involved in airway clearance, non-invasive ventilation, oxygen, lung function, and walking oximetry. So going forward, just maybe think of whatever role that you play in your center and just take from this talk whatever it is that is appropriate to you. We also just have to acknowledge that our international colleagues, so in Ireland, the UK, Australia, New Zealand, and in other parts of the world, there is no RT, so the physios will do all of these jobs. So cystic fibrosis and physiotherapy, we've likely already heard a lot about this today, so I'm going to review it very, very quickly. As we know, physiotherapy is a key element of care throughout the lifespan. It includes airway clearance techniques, inhalation therapy, exercise, musculoskeletal and continence assessment and treatment, non-invasive ventilation initiation such as BiPAP, and pre and post-transplant exercise. Patients are often familiar with their daily PT regimen. Patients receive airway clearance, education, exercise counseling from the physiotherapy team, and a relationship and rapport building is so important to encourage compliance. So let's talk a little bit more now about the patient relationship. So physios and respiratory therapists have a special relationship with people with CF. So we have this extended course of treatment over years as an inpatient and an outpatient. So physio is likely one of the first treatments that patients and their families will be introduced to at time of diagnosis. So this is something that is typically well known to these patients. And throughout their time with us, they will be seen for extra therapies, so going through maybe a new antibiotic inhalation, or maybe a different form of airway clearance, maybe moving more from family assisted to independent therapy. So we see them quite regularly. It is one-on-one therapy, so it is just the physio and the patient in the room, either doing education or doing some kind of drug trials, so inhalation drug trials, or even it could even be things like manual chest physiotherapy or one-on-one exercise and rehabilitation. It is hands-on, which is my favorite part of this job. We have the amazing privilege of being able to place our hands on people and help them feel better. So both the physio and the patient is very, very comfortable with this physical touch. And during this therapy, it's often kind of complex in one way and very, very simple in another. So the patient is often in positions, for example, if we're doing manual chest physiotherapy, they're often in positions where they're not directly looking at us. They could be lying on their side or sitting up with their back to us, and we could be performing therapy on them. It could be exercising on a bike or on a treadmill or at the gym. And they have this opportunity to really, really open up and be vulnerable with their thoughts and their feelings. And this really kind of strengthens the relationship between the physio and the patient, because they're really able to talk about all aspects of their life. And physiotherapy, maybe it's massage, maybe it's mobility treatment, maybe it's airway clearance, it's often requested by the patient because they have this perceived immediate benefit. So I've heard patients say things like, wow, I can really take a deep breath for the first time in months, or I feel so much better now that I've cleared a lot of mucus, or that walk was really, really helpful for me. And this is especially important at end of life. So if we just pause for a moment and think, what is palliative care? Like, what does it mean to you? So often to people who aren't used to this system, palliative care is the idea of coming to an end, maybe. And it's actually more complicated than that. It's not just end-of-life treatment. The World Health Organization does have a lot of bullet points on what they define it as. And they say it is the prevention and relief of suffering by means of early identification and management of physical, psychosocial, and spiritual problems. And as physios, we can really, really get involved with this. So parts of this are going to be important for physios to be involved in. For example, providing relief from pain. So things like, again, massage, mobility, positioning can be very, very helpful for pain relief. And other distressing symptoms. So one of the big distressing symptoms we'll see in a lot of our patients is dyspnea. So the physio and the RT can get involved with initiating non-invasive ventilation, maybe initiating nebulizer treatments instead of MDI treatments. So there's a lot of things that we can do to help with these feelings of discomfort. We can offer support to the patients and help them live as actively as possible until death, and offer support to the family to cope during this difficult time. And we are definitely an important part of the team. And many adults with CF receive intensive care up to the final weeks and days of life, including hospitalization and mechanical ventilation, intravenous antibiotics, and routine CF medication and therapies. So this is where, again, the physio is a vital part of this care. So when we think of palliative care, we're quite familiar maybe with the concept of palliative care in cancer. So what's the difference between palliative care with cancer and palliative care in CF? So with cancer, there's often a point at which no further effective therapy is available. So we have this concept of get a diagnosis, maybe you go through some surgery, maybe there's some chemo, maybe radiation therapy, maybe some more chemo. And at a certain stage, we can decide actually this is not going to make you any better. This is the point at which we know that no further chemo is going to help this situation. And we move more towards a palliative approach. But in CF, it's not as simple as that. It's a more complex relationship with the end of death. So a lot of this comes from the fact that there is a limited predictability of the terminal phase in CF. We don't really know that point at which treatment ceases to be effective. And often even the treatment of pulmonary exacerbations will have an effect of delaying death and minimizing symptoms. There's also a tendency from a patient perspective to consider palliative care as maybe a giving up. And this is something that our patients just are not good at doing. And they don't like to involve palliative care in the way that they think and observe palliative care to be. And then there's always that potential for lung transplant and modulator therapies. And it's a great big unknown, and it's a very, very complex issue that's really beyond the scope of this talk today, but it does bring in a whole nother layer of why it's difficult to involve palliative care and why it's different to cancer palliative care. So at our center, I spoke to our director, and she has some very strong feelings on palliative care at our center. So see, these are some of the things that she said to me. She says, I've looked after these patients for years, even decades. And when they're dying, it's important to me that I continue to care for them and not abandon them to a palliative care team. And the palliative care team provides valuable insight, but I want the CF patients who die in hospital to die surrounded by the team of healthcare professionals that looked after them when they were alive. That means we have a responsibility to learn more about palliative care and to really get better at doing it. And as I've mentioned in the previous slide, some aspects of palliative care in CF are different than other diseases. And we will often find that even our colleagues in palliative care are very confused when we tell them, well, we're going to have non-invasive ventilation and we're going to continue with their IV antibiotics and they're going to keep getting all their nebulizer treatments and physio is going to come see them a couple times a day and they're going to be up and walking. And we may even, again, if it's for bridging to transplant, they may go to the ICU and they may be fully ventilated. So even our palliative care colleagues are kind of a little confused and don't really know where they fit in this kind of scenario. And then the final thing that our director did mention, she says she thinks that physical touch is very important and that the physios are best able to do this and teach the family how to do this. So what does physiotherapy and respiratory therapy in advanced lung disease look like? So airway clearance therapies may be adapted to patient needs or circumstances. So we may maybe step in a little bit more, help with more manual techniques instead of encouraging the patients to do independent therapy. We may focus more on breathing control, relaxation breathing, and then minimizing work of breathing. We may initiate O2 therapy. We may change from their MDI inhalers to maybe nebulized inhalers because there's less effort and work and timing involved with those nebulizers. We may initiate non-invasive ventilation or BiPAP for comfort and also for airway clearance. We may start with some massage for pain relief and also as a sleep aid. So massage can be performed in any position, on any part. So you can even do hands, you can do feet, you can do arms, you can do shoulders, and it can provide a lot of relaxation and it can encourage sleep. We can work on positioning. So this could be comfortable positioning, turning. It could even just be bringing your patient into an upright position so that breathing's a little bit easier. Perhaps if the patient wishes, we can go on short walks for comfort. Often my patients just want to get out of the room. Just see something different. And even some small little things like placing a cool air fan in the room or opening a window can give that patient just a feeling of air moving over their face and just can make breathing feel a lot easier. And then in terms of working with the family, so these are these family members will know us quite well. They will have often come with their loved ones to clinic appointments. They may have come and visited their loved one in hospital when they've been here for long extended stays, and they will often know us because physio will come and see them every day. And what can we help the family to do at this stage of life? So often family members are kind of confused. They're not sure what their position is and they don't really know what to do. So we can help encourage soothing touch. Just encourage the family member to come over, hold the patient's hand, just chat to them. We can talk with the family about the patient. We can give them kind of helpful advice on what to do and how to help. So sometimes I'll actually delegate some manual chest physio treatments to the family just to try and get them to really get involved and to get close to their loved one again. And we can help the family members assist the patient with relaxation or breathing control. I've often even taught family members like lymph drainage, hand massage techniques. Again, it's just to encourage that soothing touch, get the family to really connect with their loved one, and to feel like they have a role and a really important part in with the team who's treating their loved one. Communication, I can't overemphasize this enough, is phenomenally important. So end of life planning should really happen as early as possible. And this is to try and set the patient up for, to start thinking about what they want when that time comes. We don't want to be having these conversations when the patient is at 15% lung function and really, really struggling to breathe. We want to be having these discussions very, very early in the course of their relationship with us so that we have a plan in place. Good communication between the patient or family and the CF team, letting the patient know what it is that we're going to continue IV antibiotics, we're going to continue all active care. And then good communication amongst the team. So we know exactly what our approach is. There's no conflicting messages. We are a team and we are treating this patient, with the exact same goals in mind. And if anything changes in the course of this treatment, that it is communicated to all members of the team in a very, very timely fashion. Feelings and emotions are going to be present, acknowledging them, supporting them, both for yourself and for the patient and the family and other members of your team is an important kind of aspect to remember. And if you can, involve spiritual care early if it's consistent with the patient wishes. So again, you want this patient to have a relationship with all of the members of the team that they're going to be working with. So involve them early. And then just as a side note, because our CF community is so tightly knit, a lot of patients that are admitted to hospital will often know that there's other CF patients on the floor already. So you may go from treating a very, very sick patient into a not so sick patient's room, and they'll start asking you questions about the other patients. So just be prepared for that conversation, and be prepared with your answer probably before you go in case it does come up. So I just want to acknowledge that listing for transplant is an option. It is part of the continuum of care for a lot of our patients, but it is a very, very tricky balancing act. So in the beginning, obviously there's hope. We have another line of treatment. We can go for transplant. Your lungs are not doing such a great job right now. So let's list you for transplant and move forward with that. The issues come with things like fatigue and pain that the patient will be experiencing. And there's also often limitations on palliative medication. So our palliative care team might want to initiate a little bit, maybe more morphine or like the more opioid-based pain medications, but then our transplant team don't necessarily want our patients to be on too many of these drugs. So it's, again, we're trying to balance the patient's fatigue and their pain with their ability to participate in therapy and be successful in their lung transplant. So with that, there is often a degree of guilt. So sometimes the patient just feels guilty because they really, really don't want to exercise and do their prehab. And the physio feels guilty because they're pushing this really sick and tired patient to exercise. But at the end of it all, we do know that this is the best thing for them, because if they go into their lung transplant, this is such a big, big surgery. If they go in fit and healthy, or as fit and healthy as they can be, they're going to succeed a lot better and they're going to be home a lot quicker post-transplant. Exercise, as I said, is a huge component, and managing the expectations of the transplant center. And then there's exercise on ECMO. So even when our patients get to the very, very end, where they need to be transferred over to the transplant center and maybe placed on ECMO as a bridge to transplant, they will still continue their exercise and activity. They'll be on treadmills and bikes and doing strengthening exercises on ECMO. And then there's the question about modulators. So there is no doubt that modulators are doing amazing things in the lives of our patients. But we just don't know what the long-term outcome of these modulator therapies are going to be. And really, none of us are going to get out of this game of life alive. So we're all going to come to the palliative care treatment ethos at some stage. So again, getting good at this, like these patients are our patients for life. So even when they're on modulators and they're doing really, really well and they're participating fully in life and having these amazing experiences, we're going to keep following them. They're going to keep aging, and we're going to need to see them, when that time comes. And then just one final thing to talk about, and it's actually about you as the provider. So personal considerations for you. This is an emotionally exhausting time. Okay, it's going to be very, very draining on you. These patients are often our age, and we can draw very close parallels between their life and our lives. And we have this very deep connection with these people. So it really, really can be hard on us. We are often involved in all these family dynamics. So we have this patient in the center, and then we have maybe their parents, and then we maybe have their spouse and maybe their children. All of these dynamics are very, very present throughout this stage. And we have a lot of these people coming to visit these patients. And again, this can be quite exhausting for you as the care provider. So don't be afraid to ask for support from your team. I know here we have amazing social workers that are very, very supportive of us. Your other physios or respiratory therapists who've gone through this before, talk to them, maybe even reach out to some kind of private therapy, work your way through your own feelings and emotions and beliefs around this stage of life. It will help you be a better physio or better respiratory therapist, and it will help you to work with these patients a lot more effectively. And there is always this kind of line between professionalism versus humanity. So I think a lot of the time we're really good at professionalism in the medical field. We have a very good way of telling patients what we want them to do, but we're not so good at just being a little bit vulnerable and a little bit honest with how we're feeling. And it's okay to be both. So, and you will often cross over those lines. You'll be a little bit professional, and then you'll be a little bit vulnerable, and that's okay. Very valuable lesson I learned from one of our social workers: know when to step back and let the family lean in. So ultimately, the family will take over the care of their loved one at a certain stage, and often you'll know when that is. And don't be afraid, just to slowly step back and just let their family step in and maybe provide more care or like initiate the grieving process. Don't be afraid to move backwards when that time comes. And then afterlife, something that we do quite well here, I think, is that we do a team debrief after any of our patients have passed away. So we will all get together, our doctors, nurses, the physio, the rest therapist, dietitian, pharmacist, social worker, and spiritual care. So basically anybody, and palliative care team, anyone who's been involved in the patient's treatment. We'll just talk about what we did well and maybe what we could do better in the future. And it certainly helps us to be better and to improve as we go forward. Also, consider a memorial service for the CF team. So we don't tend to go to personal funerals of our patients, but we do hold a memorial every year, and we invite all of the family and friends of the patients that have passed away in the previous year, and we celebrate the life of our patients. And just as one final note, prepare for the family to return with gifts. So, that could be cupcakes. I've actually received a few exercise bikes or maybe some gait aids from families of patients. And sometimes they want to come back because this is a place where, they spent a lot of their time with their loved one. And you have a shared experience, with them. So they will sometimes come back. And again, your place is to listen and greet and welcome these people. And just enjoy visiting with them for a brief time. And this concludes my talk.